Great. Thank you, everybody. We have a couple things, obviously, with the consultants on today. But first, I'd like to call the roll and obviously do that as we get ready to start the meeting. Give me 1 second. I will pull that up. Okay. I will start with Bonnie Berman.
Here.
Lori Stevick Rust.
Here.
Jennifer Drost.
Here.
Tina Hotchwalt.
Here.
And Varan Mahajan. Trey Addison is here. Greg Sini is not present. Okay, we're in good shape. And then also we've got the meeting minutes from our last two meetings. I think we do need to get those approved. I don't know if everyone has had the chance to look at those, but if we can get a motion to approve, that'd be great.
So moved. Second.
Perfect. Okay, with that said, I will be taking our meeting notes for the day and shooting those over to Greg. So once we get started, we can go from there. But that being said, I don't know if I did share data or some Alzheimer's Association insight and perspective prior to or after, after our last call that really highlighted some of the key data points. Some of that was Ohio specific, and then also some of that was more broad from a national perspective, but really provide some insight and perspective on where the disease is at, where Alzheimer's is at specifically, as well as dementia, and then also where things are trending. One of the key points from the last report that I sent that was done in 2021 was really around diversity and health equities. And there is a focus of that for the task force, so I wanted to make sure we included that in the data set that we delivered to you all. We also shared that with everyone on the entire task force in the share file, along with some other data and legislative information. So I don't know if everyone has had access or been able to get access to the share file, but I've been able to share some of this information just simply because it goes beyond just our scope of work on the science committee, but it really goes for everyone's scope of work, if that makes sense. So that being said, I will kick it over to Lori and or the consultants, and we can start the meeting.
Thanks, Trey. We met earlier to talk about the agenda for today, and we had a really, I think, nice introduction and conversation, both Trey, myself, and Greg with the consultants. And I know there was a lot of conversation and a lot of information. So I think we thought, and what we shared with the consultants was sort of our process as a committee, what we've been doing in terms of the creation of documents, managing the information, trying to solve for what this committee has been tasked with. So I think a better use of our time today would be to just allow the consultants to sort of ask the questions, the team to be able to ask questions of the consultants so that we know that we're in sync with helping support the creation of this document. So with that, I think I'll just turn it over to the consultants to be able to our squirrels, our sage squirrels, to be able to share the process and meet the rest of our team. So
thank you, Lori and Trey. This is Yonda, and I love hearing you call us the squirrels, because when we hear the consultants, it just doesn't sound like us. So I appreciate that. And I just want you to know that normally Debbie is our lead person. She's a little under the weather today, so she's observing, and I'll be, for what it's worth, leading our discussion today. We do have a couple of people with us today that are part of our team that weren't on with us at the last meeting. So I'd like to give Jill and Leanne an opportunity to introduce themselves to the group, and then I'll tell you a little bit about what they're doing, and then I will jump in with if you're okay with it, with some questions. So Jill?
Hi, I'm Jill Earle, and I work for Lawrence Policy Consulting. Excuse me, and I will be taking the meeting minutes today. I live in Fishers, Indiana, and I have two little ones, 8 and 5. And I also am a caregiver to my mother, so this is not only professional but personal for me.
Hi, thanks everybody, or thanks Jill. Hi everybody, good morning. I'm Leanne Kingsbury, and I have to tell you, I have somebody repairing my roof and they're directly over my head and pounding at the moment, so it may be really noisy. And the lawn guy just showed up and he's outside my window. So let me just apologize for all of the background noise. I will mute quickly. I am an independent consultant. I live in southeastern North Carolina. I was formerly with the Lewin Group, Healthcare, Human Services Research and Policy Organization. I am gerontologist by training and education, and also have a master's in public policy. So the kind of intersection of aging and disability services and policy is really, really my interest. I have a background in person-centered practices and person-centered care, have run a couple of provider agencies. So I tend to really think kind of from the provider and the family perspective. I'm also a caregiver. So I really connect with Jill around the long-distance caregiving piece. My mother is also a couple of hours away from me, and I'm an only child of an only child of an only child, which means there is nobody else out there to help provide care. At least from a family standpoint. So this for me also is very professional work, but also really personal. It means a lot to me to really pay attention to these issues and help figure out, how we move ourselves forward in a really productive way, because we know we have to. So I appreciate the opportunity to join all of you and look forward to this work. Thanks.
Thanks, Leanne. So Lawrence Policy Consulting is a small 2-person firm, not dissimilar to Sage Squirrel, that we added to our team to help us build out capacity for research and activity coordination. And as Jill said, she'll be taking meeting notes throughout all of the meetings that we participate in going forward. And the other thing that she'll be doing while she's taking notes is flagging action items. So if there are any activities that any of us, whether it's a member of our team or whether it's a member of the task force, that says, I will do something, Jill's going to flag it for us. And one of the last things that we'll do in each meeting is just ask her to give a quick report on any action items, just to recap anything that will come out of this, just to keep us marching on pace. Leanne, we indicated when we spoke with you last week that we had added a couple of subject matter experts to our team, and Leanne is one of those subject matter experts. Not only does she have this very deep and broad experience as a gerontologist with an interest in public policy and person-centered practices, but practically speaking, she's also an extremely skilled facilitator. And there will be a point here where we will need to probably be conducting some very active facilitation of all of the meetings that we are in to move certain things along to consensus or decision points. And Leanne's going to be supporting us with that. As you know, so she'll be sitting in on these to get a good sense of where everybody is right now. So by way of just a brief update, we're still kind of getting our legs under us. One of the activities that is still pending is our access to the shared drive. We don't have that yet. We still are hoping to have it within the next day or so. Debbie has been working actively with ODA to get that access, but we are still flying a little blind as far as some of the materials that the groups have produced. In particular for this group, we're very interested in seeing and haven't seen yet the 3 worksheets that you have talked about. So if those are something that could be emailed to us, we would definitely appreciate that, because we do have the data and information that you shared by email the other day.
We'll make sure that you get that today. We have the completion of all of them now, so yes.
Great. No, that's great to have. And like you said, we did get the data that Trey shared last week, all of the Alzheimer's Association data, as well as the memo to ODA that outlined some of the potential recommendations and other state practices that you were examining. So we do have that. We did have about a 2.5-hour conversation with the director on Saturday morning, just kind of working to get aligned with her on what's happening with the task force as a whole and the committees. And we're still kind of working through some things, but one of the things that really jumped out to Debbie and I in the course of our conversations over last week was the fact that, one, people have said, oh, you have about 8 weeks. Well, realistically, we have maybe 5. Because of the fact that there are reviews and approvals that need to happen for any report that goes out from a government entity. And so our time frame is extremely compressed. And a lot of the topics that are under discussion here cross committee lines. So we are really looking at how do we engage with the task force more broadly. Whether that's through a subcommittee made up of the actual committee chairs, or how do we do it with the task force itself? That was something that we had some conversation with her about, and we'll keep you posted as far as what comes out of that. Don't alter your meeting schedule or anything at this point, but we will definitely kind of keep you posted. So. And so as a result of that, we're still kind of working on the actual concrete plan. But again, I think we have meetings this week with ODA around data, as also around the public transparency requirements. And so those are all big components to finalizing our plan that we have just not been able to get that information yet and are working to do so. So that's kind of, again, where we are update-wise. I do have some questions for the group. So unless you have questions about our update, I'm happy to start to jump into those questions. But let me pause there. Okay. All right. So we have gone back to the legislation to a certain extent, talked to the director, and one of the things that we had noted was the fact that the legislation outlines those 28 topics, and it says that the task force will present findings and recommendations. And we're not completely sure why, if it was something in the RFP and us, or something in our early conversations when we signed the contract with ODA, but we came away last week thinking that we were going to be very focused on the recommendation piece of this. But we actually think we're missing the findings. And so this week with the committees, that's really what I wanted to talk a little bit more about, which is, one of the goals of this report is to paint a picture of the current state of dementia care and services, or care and services for persons with dementia, rather, in the state of Ohio, which really kind of calls for not just data, but some conclusions that are drawn as a result of data, experience, policy. And then theoretically, those findings, those conclusions would lead you to recommendations. And we are definitely seeing recommendations. For instance, the memo to ODA was a good start to that. But what's less clear to us is what might have been some of, and I'm going to use the word findings loosely because I understand that a lot of this still may not be quantified yet. But we would like to kind of get some insight into what findings or conclusions the committees came to as part of moving forward with recommendations. Your group actually is a little farther in some ways on that than some of the other groups are. So can we just kind of, and if we need to go topic by topic in the legislation, we can. I don't have the list of committee assignments in front of me. I just have the legislation itself with the bullet points. But I certainly would like to just hear from the committee any conclusions that you came to based on data from Alzheimer's Association or other organizations, Dr. Drost's practice, Bonnie, your work, anything that's out there that sort of led you to say, here's why we're recommending what we're recommending. And maybe even what led you to develop the work in the 3 buckets that you talked about. So let me shut up there and turn it back over to the group.
I think one of the things that we've, at least in our conversations, have come out with is really just the syncing of information among people, caregivers, the lack of information even caregivers may have, but also even from an institutional level, just overall coordination. I mean, even at the association, you know, we work with a lot of different groups, from nursing homes to pretty much everybody in the spectrum. And, you know, the training for staff is not succinct. We don't really have a methodology for that as a state. The accreditation of memory units and things of that nature is not really strong in the state. But even taking it a step further, looking at where are we going to be at now that the state is aging and Alzheimer's and dementia numbers are creeping up because of the state is aging. How are we getting ahead of this and thinking about it? I think the task force in Merit is designed to do that. But I think Bonnie said it before, we want to be ahead of the game and be a trailblazer for other states across the country. So I think we need to be thinking about where the trends are going to be able to prescribe to those trends, as opposed to just kind of, you know, putting solutions out there or looking at things in a sense of, well, you know, we'll see what happens, but this is what has been tried and true. The trends tell us one thing, and I think COVID exacerbated that from an aging standpoint and the folks that we serve. So that's just some brief insight from myself, but I'll turn it over to the group.
Can
Please.
I? That was really good introduction, Trey. I think that when Trey mentioned that let's be the kind of the trailblazers, one of the things that you all mentioned on the last call is, you know, how many of these plans have not necessarily resulted in what we want them to result in. And so to echo what Trey said, we would be very sad and a little bit humiliated if this sits on a shelf. And so it's very, very important that we kind of, as Trey said, go back and to see not just what's missing, but what's missing. And with the what's missing, I would say that when you read the legislation, I don't want to use the term gobbledygook, so I won't, but language matters. And Trey and I have had these discussions, and even as committee members, sometimes we don't use the same words to mean the same things. So as an example, I think we would be remiss if, when what Trey was saying about people don't all understand the same thing, people don't understand the difference between dementia and Alzheimer's. And we would do the rest of the country an enormous, I think, favor if we once and for all kind of separated that out, helped people understand what these words mean and understand what are symptoms, what is a disease, these kinds of things. Secondly, and Trey and I had this kind of offline conversation with this, is we are blessed to have an Alzheimer's Association that is so incredibly active and helpful, both nationally and locally. but we have not engaged as much, if at all, with some of the other associations, meaning, does anyone really know what's going on in frontal temporal dementia or Lewy bodies or some of these? And if we continue with the path and just go with what we know because the Alzheimer's Association is so good at providing it, then we are creating a future that also is not fair. And as you can tell, I kind of feel strongly about that, so I will be quiet.
Are there associations in Ohio relative to other types of dementia?
I have no idea, Trey.
Not that are active, and we've recently, as of I believe maybe 3 or 4 years ago, when the association kind of merged and became the Alzheimer's and Related Dementias Association. I think that was a big thing for us because we realized, to Bonnie's point, we've got to think at scale and start to cover at scale. So even in Ohio, we're servicing pretty much everybody, but we're even at capacity in some ways as it relates to that. So to answer your question, really it's the Alzheimer's Association, and we're kind of doubling down and trying to scale out our specific dementia work as we see more individuals who are developing dementia and other types of different types of dementia. Excuse me.
So with everybody at capacity, and that is of course true, it becomes very difficult for us to even figure out what some of the statistics and data mean. So when we say, and I don't think there's anyone who knows this, but maybe there is, let's say only 40% of the people have a diagnosis. Is this dementia? Is this Alzheimer's? And we tend to use the words interchangeably. And we would be remiss if we don't figure out that data or have a plan to figure it out, or at least to acknowledge that this is confusing.
And I completely support that, but I think that raises
Yonda, this is Leanne. May I jump in for a second? If that's you speaking, you're breaking up on my end. Is everybody else hearing Yonda okay?
It actually, I think it was Lori, but I was.
Okay, I'm sorry. Yeah, thank you. Whoever it was,
okay?
thank you.
Can you hear me okay now?
Better.
Yes, thank you.
Sorry, I don't know what happened there. I was just saying that I think Bonnie brings up an important point, and our committee has talked about this from the very beginning, which is the interchanging of words. Yes, they matter, and they matter from a training perspective and from a clinical perspective. So, I think the part of what we're hoping to accomplish in this task force is some consistency in the education of the use of those words. So primary care doctors don't send a family out the door saying, well, it's memory problems, it's beginnings of maybe some dementia, and the words are very soft pedaled. Families leave going, I don't know what I'm supposed to do. I think the added piece is, as clinicians, we definitely refer families to the Alzheimer's Association and are very clear to say the Alzheimer's Association, well, that's the name of the organization, is not the only thing that they serve. We have a pretty big frontal temporal unit in a hospital up here in Cleveland, and we send a lot of people over to the Alzheimer's Association to say, you're going to gather a lot of information there too. So I don't know that I wouldn't be in support of the idea of saying we have a frontal temporal committee or a association. And I know you're not saying that, Bonnie, but I think that would be what we want to make sure that people understand is we're talking about a disease of the brain. And it comes as from a variety of places, whether it's vascular or frontal temporal, but we have to have our training and our education mirror what the science is telling us, as opposed to a watered down version of the science, which I think is where we sit clinically in a lot of places. And so my hope is that part of this task force is going to be able to come up with, here's our findings, to your point earlier, of the findings are telling us that this is what's happening. We're missing the boat. We're not providing the right kind of information because we're not training well enough, whether it's caregivers who are professionals or family members who are providing the care. And that would be part of our recommendation, is that we find a way to systematically up the level of training in using these words properly and then helping families know what to do with that information.
Hi, this is
I agree. and
Join. I just want to mention I just joined. I had to join late. I was in a previous meeting, but I'm from Ohio Department of Health, and I just recently am on the committee for our director. So I apologize for being late, but I was actually meeting with the director. So thank you.
So,
Can you hear me?
yes.
Yeah. Okay. So this is Jen, and echoing those points, and I think from the clinical standpoint, and the primary care, primary or diagnostic point, at least
You're breaking up a
two
lot.
of the overlap.
You're breaking up a lot. It's hard to hear you.
I turn my video if that helps any. I'm in between patients, so I'm in, a parking lot. So is it better?
A little.
The video. Okay. I'll try again. If not, I'll call in then. So the distinction between the different dementias, I think, is important, but also making sure that we are lending word to there is a lot of overlap and increasing awareness of the overlap between dementia syndromes, within the population, within the literature and research. So that's also important to acknowledge, though that overlap does make training and education that much more difficult. I think from my standpoint, the other thing that really adds into this picture, systematic ageism that's built into our society and into our our structures and systems and access to things that also inhibits people's understanding and awareness of dementia and check out.
Jen, you broke up a lot during that. I think you may have been speaking about ageism, but I'm not 100% sure that I caught all of that. And I don't know if I'm speaking for the whole group or not. Was that actually the case?
Yes. Yeah.
Okay.
If there's specific points, Jen, maybe you could put them in the chat, even if it's something that we could read, might be helpful, because it is breaking up, unfortunately.
Let me see if I can call in instead.
Okay.
Yonda, while she's doing that, I'd like to just make sure that you're able to access something, and I'm so glad that the Department of Health is represented on the call, is that Trey mentioned the memory care units. And there was legislation, Trey, how long ago? 3-4 years ago?
Yes.
3-4 years ago, and it was House Bill, it's either House Bill or Senate Bill, I'm not sure, 470, House Bill 470.
Yep.
And I don't know if you all have a copy of it, but the Alzheimer's Association worked with other contractors, and I was lucky to be one of them, to develop a report on how we should be assessing, regulating, assuring quality, et cetera, in memory care units. To the point where the Department of Health was so wonderful in that it developed the actual survey instruments that could be used. But as importantly, as a starting place, one of the things that the report on 470 did was to say, and this is exactly what Lori was talking about, if memory care units are to be assessed, regulated, and to say, you guys really know what you're doing, then there should be an obligation, if you're going to be a memory care unit in the state of Ohio, to make sure you are reaching out to the community and training or providing education or assistance to caregivers and others in the community, so that people do not come into care communities because of a crisis. They already know how to provide the right kind of care and caring that is person-centered. And so I guess, I don't know where that landed, but it speaks to everything that everyone has said here today. Trey, I don't know if you have more on where that is.
Yeah, I think at the time I was actually in a different with AARP in the same capacity, and I think the one problem that we were running into is just, again, it goes back to education and really getting people in at the community level to understand the resources they have, but also reversing that. And one of the things we did at AARP was educating them on what is a memory unit and what is not, and how do you designate that, or in some cases there is no, you can kind of slap the shingle up and say you're doing it, but what does it really look like? And I think as we dived into that, to Bonnie's point, we probably want to bring that back up, especially knowing the Ohio Department of Health is the vice chair of this task force, to bring that back up, because it's a big issue. And again, we've seen the data, and I think that's what should drive not only the narrative of the science committee, but the narrative of every committee. And the data shows most parts of Ohio is aging, and the disease is growing because of age. So if we're not thinking through that process and that timeline, and we're not equipping ourselves with good regulation, not regulation for regulation's sake, but good regulation that can help people, we're probably going to miss the boat on this. And I think that's the intent from providing the resource and information and solutions in the memo that we sent at the beginning of the task force and shared with this committee was, here's where states are doing great work. Georgia's done some good things. Florida's done some great things. How do we steal from them, but at the same time create something innovative in Ohio? And thinking through solutions, because we're in June and we really got 5 weeks, so we can't talk about philosophy. We have to think about solutions. So, that's kind of where I'm at. And Lori and I just talked about that briefly prior to this call. There's no way we can think through everything and sift through data points. It's a matter of solutions and taking from where other states have done good, and then also adding sort of an Ohio flavor to it.
So there is still some the plain language of the legislation does say findings, and I don't want to over dwell here, but you're indicating throughout the conversation, we've heard a number of statements that sound a lot like findings, and that's not a bad thing to kind of hear those and start to pull those out. But what we would also like to explore a little bit is what's the basis for those findings? So, you talk a lot about the fact that there is confusion, frequently driven by some of the language issues around this, and I totally get what you're saying. And it seems like that's the kind of thing that would be fairly self-evident if you just talk to a few people who have gone through this as people with Alzheimer's or dementia or family caregivers. But what is that what you basically have had to do is rely on your professional experience, the experience that Trey brings through the Alzheimer's Association, or is there any other data or literature that you looked at that said, yes, people are confused?
Yeah, I think that the findings that, if you were going to say summarizing the data that's even led us to that place of whether it's just in our own clinical practice or as part of this committee, you can just simply look at the data of diagnosis. When you talk about 68% of people are misdiagnosed or it's undertreated, meaning, again, that data tells you something that, back when I started doing this 30 years ago, if you walked into an assisted living, you had a couple of people who carried a diagnosis. If 72% of people in an assisted living in the state of Ohio actually have dementia when they're evaluated, but the majority of them are not carrying a diagnosis, and they're certainly not carrying a very specific diagnosis. It's a generic, which then leads to mishandling, poor care, lack of training, knowledge about what do you do with somebody who has frontal temporal dementia versus somebody who has Alzheimer's disease. So I think those findings that you can mine in the clinical data drives the recommendations, because what it says then is we've got to do a better job upon entry into a senior care community, upon entry into an emergency room, upon entry into a primary care practice. We have to do better with identifying and diagnosing, and then your recommendations for how to more systematically across the state of Ohio make your training modules better, make your recommendations, looking at how do we monitor who calls themselves a memory care unit and what kind of training that staff has to have. Because right now in the state of Ohio, compared to many other states, there is no difference. You're going to charge a premium to be in a memory care assisted living facility, but your staff may or may not be trained any differently than somebody in a nursing home that is a Medicare, Medicaid bed. And for me, I think that's the injustice of families not understanding that, thinking I'm paying $7,000 a month. These people really must know what they're doing. Then why are they calling me at 3 o'clock in the morning that my mom is yelling? So I think that finding alone will drive us to the recommendation of needing a more structured, systematic way of training, of regulating our senior care communities at the very least.
And can I?
I'm sure. Yeah, please.
Lori is so on target, but I'm going to give some specific examples because I think that's what you're looking for, Yonda. How are we going to really state this? What's the footnote going to look like? And if you would all like, I can give you the final copy of what was submitted for memory care units. I can't say what the departments did with it, but that's up to you of whether that's accessible to you or not. As far as the training that Lori talked about, a specific example would be the following. Very few people know that in the state of Ohio, there is a line item for every state-supported medical school, which I believe there are 7 in Ohio, to say that every school of College of Medicine must have an Office of Geriatric Medicine that is funded in part by the state. The legislation as it was written, and maybe it's been changed, is that through this or with these funds, we should ensure that every medical student who graduates is able to care for and about their aging population, or there's an exact wording there. What are they doing with this money? What is that line item? Lori will say to you, she'll say, I didn't even know there was this line item, because most people will say know that. But the question becomes, well, what is their obligation? Let's survey them. Let's find out what they're doing, and let's see. And let's probably say as a recommendation, no, you all must be doing this. You can see I have an opinion. Sorry.
No, that's.
I used to run one of those, so I know that's. And Jen Drost, of course, works with one right now.
So the memory care, that report on that legislation from a couple of years ago, if we could get that, and one of the things, just to be clear, that we are trying to make sure we stay in sync with ODA on is the fact that this is a public commission or public task force, public committees, and the shared drive is the official repository of documents. And that's why us getting access to that is so important, because we really shouldn't have anything that's not in that for these purposes. Is it possible to get that report though, and make sure that it is on the shared drive? Because I think that could be another place that we could mine for some of these findings. Bonnie, you're muted. I
will tell you that we had top experts in the country who were, Paula Carter worked on it. This was a really big deal. All Trey and I can provide for you is the report that we that was submitted to the Departments of Health and the Departments of Aging. At the time, Bev Laubert was the director of the Department of Aging. Through a variety of meetings, they did, with a couple of changes, sign off on the report. What happened after that, and if it got to the legislature, and as Trey's shaking his head, I'm going to assume that the legislature might be a teeny tiny bit out of compliance here, but I don't know how or how that works. So I can absolutely, but the copy I'm getting to you is only the copy that the consultants forwarded to the state and was changed for the state sign off of the departments. Because the way the legislation was written, it was the Department of Health and the Department of Aging that was to submit a report to the Department of Health by date certain.
Okay.
Bonnie, when was that? When was the report?
I believe it may have had to be submitted, I think maybe February 8th, 2018. Okay. I mean, all the years are just going together right now, but
I can send 2017.
I'm sorry.
Yeah, the law went into effect March 21st of 2017.
Okay.
And then, yep.
Okay, so the report was around 2018 then. I'll see what I can find out here as far as the Department of Health, as far as, and then what we did as far as our next steps, if there was anything else that we still have going on, with the memory care and in relation to the report too.
Terry, your survey folks were amazing in that they just, the way they said it is kind of like the way this report is going to be written, I think, Yanda, and that is, I said, let's just talk about what's important, and then we'll write the regs. Let's not set the regs in with what's important. So we came up with what's important, and then they did their part. And then actually we had top experts in the country actually come up with the actual measurement and quality standards. So we'll get that over to you.
That would.
Yeah, and I'll follow up with our division of our that area just to see if there's any, progress, or if they have any additional data or anything that would kind of help with this. So
sometimes when there are changes in administration, things don't, just have to
pause. If I could pause this for a quick second, I see that Jen did, she's still having trouble calling in. She added a comment. I can either read it or you could go to the chat just for record's sake. She was commenting on ageism, which is what she was trying to say. And then she had her hand up. Jen, are you still with us? That if you had something else you wanted to try to add?
I didn't know I had my hand up. I left and came back, so I don't know if that's any better.
Much better, much better. So I was trying to read, I told them I directed everybody to the chat, but if there's something specific you wanted to add, I can hear you much better now.
No, that's obviously an overarching, theme with aging and with caring with, for older adults and their families. But I do think that it weighs heavily in, certainly kind of with our issues, we're talking about pre-diagnosis, risk mitigation, et cetera. A lot of those things, the lack of forethought, the lack of, public support, et cetera, for all of the healthy aging things are, rooted really in ageism.
So I totally get where you're coming from. And are there any sources, that you would point us to sort of be able to build some flesh around that? I know I've certainly done some reading about ageism. I certainly, but I don't want us to necessarily go off in a weird direction but there's a finding there, I think. But I want to make sure that we can support a finding if we include it. And so if you've got any reference materials, I don't know, Leanne, if anything is sort of occurring to you here
Yeah, this is Leanne. I would need to do a quick search, but in fact, I just Googled. I'm sure the Gerontologist journal has some, I mean, there's been lots and lots coming out. I'm happy to do a couple of quick searches on that. It's one of those topics that, and I really appreciate Jen kind of talking about, kind of using that as part of the frame for this, because it really is. I think that the comment, Jen, that you made in chat is just spot on, which is, that sense of, oh, well, this happens, this is just a part of aging. People get older and, they forget some things and forgetting some things once in a while is one thing. Developing any dementia and then needing support and care ongoing is a whole different thing. So I appreciate the mention of it. So yeah, I'm guessing gerontologist. Off the top of my head, I don't know if ASA has anything, but I'm happy to do a quick search.
COVID and how it did everything. But around aiding and caring for older adults in facilities, those with dementia, et cetera, over the last year. But I'll look a little bit for something specific.
To build on what, I'm sorry.
No, it's okay. Go ahead.
To build on what Jen just said and your question, Yonda, of like, where's the data? Where are the sources here? One of the things that the Alzheimer's Association and the CDC, I think, have been so good at in the last year, and I think part of the racial inequity part started this, is that let's move this away from an individualized medical care model to more of a public health model. And if this is a public health model, some of the things that we've talked about have to do with, we have, God, I don't know, somebody else has to talk about how many health departments we have. I think it's 122 or something. And the question is, from a funding standpoint and a whose responsibility standpoint, whose responsibility is this? Or who's at the table? And that becomes important from a funding standpoint because, as you know, Yonda, the Department of Aging is not always equipped, either funding-wise or priority-wise, in this arena. It's Older Americans Act stuff. And so the question becomes, is this for the administration in general? Because it does have to do with business, it does have to do with community, it does have to do with every single transportation, highways, every single department. And then, of course, the brain health part of it, has to do with people in their 20s, 30s, and 40s. And an administration lasts for, 8 years and can't necessarily prioritize that, as you know. And so the frame is one that we have started talking about here in Ohio. I think we can be very bold because we have started, and the Alzheimer's Association and CDC have given us that opportunity, but this committee has not yet really, we've talked about it, and it's what Jen brought up, but boy, the Department of Health and others have this is about somebody else picking up some slack here.
So this is Jillian, I wanted to kind of build on that. One starting point is, and if this would be useful, and you may already have access to it, but as part of some of our surveillance efforts, we have included both the caregiver and the cognitive health decline modules on our BURPIS. And if you'd be interested, I could get the most recent data that we have just for this committee to kind of look at and see where we're trending. And I don't know, and I'm assuming, especially Bonnie, as you mentioned, the CDC, CDC does have that publication, that roadmap, where it kind of is the guide for like health departments that might be useful as far as some of the recommendations, if you'd like me to forward that to this committee, unless you already have it.
I don't know if they've got it because I don't have the shared drive, so certain, but it sounds like that would be something that would be useful. So, okay, so we've got just a couple more minutes here. I want to be respectful of everybody's time. And I just have one more question that struck both Debbie and I kind of coming out of last week's conversations with the committees. And Jen, I believe, has touched on it. It's gotten a couple mentions today, and that is the impact of COVID and what learnings are there that have come out of the COVID pandemic that might be specific to the work of this task force and this committee?
Well, I will say, I mean, this is, I think, just repeating and reiterating again back to quality of training. I think with COVID shining a spotlight on this is a terrible thing, but if family members are not in there watching and monitoring, what they were seeing is there were many people that were providing care in these high-risk, vulnerable units that absolutely had no business being there because it's not regulated. The training wasn't there, and that families, I think, didn't realize until their absence how much they were providing that supervision and oversight to say, no, this is what happens with my mom with her dementia, almost as if they were the trainers of the staff that they were paying to provide care. So I think COVID really did put a big bright spotlight on that. And I also think that many of my caregivers who did not want to put their loved ones, who really had to make a decision, and their loved one really belonged in a community, in a facility, held back, of course, because there was no visitation and weren't willing to do that. And by default, came up with creative ways to use more home health, more other supportive services. So, you know, in the work with my colleagues who do a lot in senior care community development, this was a struggle because I think now people are going, okay, wait a minute. For that $7,000, $8,000 a month, I didn't want my mom to go there. Here's what we cobbled together at home, just figuring it out ourselves. And so I think there's going to be a challenge both on the caregiver side and on the community side of, in the absence of families filling in the holes, or in the absence of a family member coming into the emergency room, speaking on their loved one's behalf, the system is not prepared to manage people with cognitive difficulties at any level. And I know that's a gross overstatement when I say it that way, but I think that we all sort of working in healthcare know that, but this was like that bright, angry spotlight for the families going, our needs as caregivers is not being met. And so I think COVID has forced us, and I think healthcare is going to have to do a lot of moving parts, both on the acute care and the post-acute care side as a result.
Yeah, Lori, I think she's spot on. And you know, I think I mentioned it kind of earlier, the training thing was the big one. And the ability, the caregiver, when they were present, was really the watchdog for staff. And we saw that time after time after time in talking to our program staff who lead support groups, that the staff just wasn't equipped when the caregiver was out of the setting. And even in some instances, we would, we get reports and information from people when visitation was able to happen through a window or outdoors, caregivers were able to start to see certain things that were different than when they were involved. So I think doubling down in the state, there was legislation previously to address staff training. I think we've got to look at that again, even if it's not as broad as it may have been. We may want to get more surgical in our approach and say, look, if you're working at least in a memory unit, you need to be trained on X, Y, or Z. Those training standards are out there. States, progressive and conservative, have adopted those standards simply because it really protects the entity that's taking care of the loved one. And I think to Lori's point, COVID kind of highlighted that, the lack thereof from a training standpoint.
You know, Trey took the surgical approach. I'm going to look at the 30,000 foot approach, which is, that's why we get along so well, is that absolutely right, has to be the training. The question is the training in what? And how do we frame dementia? And one of the issues that was incredible to us through COVID is the assumption that people with dementia cannot learn, cannot think, cannot do these things. So much of the social isolation was because, well, of course they can't social distance. Of course they can't remember to wear the mask. And no matter how hard we tried through webinars to help help staff and associations understand that's not true. They can do this. We can figure this out. So it's that which you train them in, it's how you frame it. And that is sorely lacking because they took the easy way out. I'm not saying it was anybody's fault, but it's also our responsibility to have changed that frame so that family would expect more. And that's all.
There's some, really good stuff there. And, just anecdotally speaking, I've never had a loved one with Alzheimer's. I've had more extended family members that have had Alzheimer's, and I've observed some of these challenges. But I was my father's caregiver basically during the last couple of years of his life, and he was dying of lung cancer. And a point came, and I had actually been an executive with a long-term care facility company that had facilities across the state of Indiana. And there came the day when I had to put my dad into a nursing facility, and I was lost. And because it's like, we frequently operate at a very different level than people who are at the ground level. And just knowing the right questions to ask, knowing, more concretely what to look for. So I empathize personally with some of this, and translating it into the report is a steep climb. But I think this has been a helpful conversation. And I know we are out of time. We may be reaching out via email. Again, don't disrupt your meeting schedule right now, but stay tuned as we continue to work with ODA. But you may get some follow-up questions by email as we work through some things. So just keep an eye out for those. But otherwise, I'll turn this back over to the chair. Jill's been taking notes. Jill, I don't know if you've flagged, I'm sure there's a lot of I will send this report type action items.
Yes, excuse me. And Lori is supposed to email the 3 worksheets. I'm not for sure what they're actually called besides the 3 worksheets. And then I wanted to, on Jolene, she is to send the modules for the.
Yeah, I'm gonna look. I do need to check with Tessie to see. Everything is public, so I'm just not sure how all the documents are being shared just because I'm newer to the committee. But I'll check on that. But what I plan to do is send both. I can send you a link to the CDC roadmap if you're not already familiar with that as far as public health and the role. Oh, you already have it? Okay. And then the other would be the data that we collect on our BRFIS, that's the cognitive decline and also caregiver.
Okay, and then is that related to the Bill 470 or not?
No, it's not. That is something that's a state survey, but it's part of a national survey that CDC coordinates, but we coordinate it for the state. I also mentioned I'd follow up. I need to, brief to see the status of some of the other legislation here and the results of the what had been done in 2017. If I can ping somebody down that has it. So.
Sorry, I was having technical difficulty. Can I make one more point just to piggyback? We're kind of finalizing or commenting regarding training. Everyone can hear me okay. I think, and again, I'm going to borrow Bonnie's language, to be really bold about this. Training is one thing, but when you have a workforce that is providing the primary care needs, particularly in facilities, but also in home with your home health aides that are minimal training. They are not paid or supported very well. They're looked down upon as kind of less than or not an active part of the care team. It really needs to be much more than just training of the comfort is really important across the board from care for our patients and living with dementia, or providing physical things that are really rationalized, take care of this.
You're breaking up pretty good here, Jen. I think that just of what I heard was the important focus on, this isn't even just about training for aides. It's about looking at it more systematically of how do we elevate the position, the importance of the position, and make them an active member of the care team, which I think is an important point. I hope I captured what you were saying.
Yes. Thank you.
All right, well, I'll turn things back over to the chairs for now to wrap it up. I see where Bonnie's got to go, and we're definitely past your hour. So thank you, everybody.
All right, thank you very much. I think at this point, we'll go ahead and adjourn the meeting, and we will keep with our subcommittee meeting schedule, and we will wait to hear back from our squirrels as to what they may or may not need from us in terms of coming in, and we'll adjust our agenda accordingly. So thank you, everybody.
Thanks.
Thank you, everybody. Nice meeting you.
Thank you.